But we also use rapid acting and short. Sorry, we also use short acting, rapid or even short acting. We use them too for long term home control, right? Yeah. So of course we use them for emergency compared to the long acting. We use the short acting for emergency like DKA, HHS and stuff. But also in chronic management of DM1 especially, right? We can use the long or intermediate acting, but we also the short acting to play a role. So the question is why? What role do they play in chronic management? Exactly. So basically, you are your goal in treating, right? DM1 is to take over the function of the pancreas. Pancreas is not working. They have insulin deficiency. Insulin is literally zero or close to zero in these people in the blood. So you as the physician, you're taking up the function of pancreas. That's what we're doing. So for me to understand how I will dose a patient with with DM1, I need to understand how the pancreas normally, right, releases insulin. And there are two major pattern of insulin release. We have the basal insulin, that is, the pancreas will always release insulin at a basal level, whether I'm eating or not, fasting or no matter what stage I am, insulin is never zero in the blood. There's a basal level of insulin. And then there's this what? The postprandial spike or bolus insulin that's released in response to what? Glucose spike right in the blood, right? After eating. Good. So you tell the physician that's what you need to mimic. That's why most people on insulin replacement, they are on what? They either intermediate or long acting insulin, right? To maintain the basal insulin level in between meals. And then they also take what? They take short acting insulin, right? After each or just before eating for the bolus insulin. Does this make sense? Yeah. So how do you know if the bolus dose or the basal dose of insulin, how do you know if it's adequate? How do we know we're not giving too much or too little? We measure. So people with that right, they measure their glucose level after eating as well as what? Between, before they eat, right? Between meals. During the fasting phase, they measure glucose levels. After eating, postprandial glucose, they check it. So the postprandial glucose level tells me about the adequacy of the bolus insulin. While the fasting glucose tells me about what adequacy of the basal insulin. Right. If I see that the basal insulin, the fasting glucose level is consistently low, then I'm giving too much basal insulin. I have to decrease the dose of the basal, the long acting or intermediate acting. But I won't touch the bolus. But if I see that the levels of glucose after eating is constantly too low, what do? You decrease the level of the bolus insulin. You're giving too much. And vice versa. If the level of the basal glucose, fasting glucose is too high, then I'm not giving adequate basal insulin. I have to increase the dose of the either intermediate or long acting. If the level of the postprandial is too high, I have to adjust the level of the bolus, give more bolus insulin. Make sense? What is there are two phenomena in diabetic patient called Dunn's effect. Have you heard of that? Dunn's effect and Smoge's effect. All right. So what is Smoge's? It's it's rebound hyperglycemia in response to what? Hypoglycemic episodes. That's what Smogy's effect is. So rebound hyperglycemia triggered by what? Hypoglycemic episode. What does that mean? Patient with Smogy's is very somebody that's taking too much, likely basal insulin, especially at night before they go to bed. So either they take too much bolus insulin before they eat the last meal of the day, or they are on the dose of the basal intermittent long acting insulin is too high, which is something they might take before they go to bed. So when they take too high insulin before they go to bed, what happens to the glucose level? It's going to be too low sometime during the night, correct? And that will trigger what? Sympathetic, right? Activation. Glucagon will be high. Catecholamines high. Growth hormone high. What would those do to glucose now? They'll kind of cause a rebound hyperglycemia. So when the patient wakes up in the morning and they check their what? The first glucose level in the morning, what happens to glucose? It's going to be high. Yes? But what happens to the glucose level throughout the day? Normal. Throughout the day. Only the early morning glucose is high. And then they check the glucose level at night. It's also going to be what? Low. Sometime at night. But only the early morning glucose, right, will be high because they have an hypoglycemic episode, right, at night. Too much. It could be either one. The point is the glucose, the insulin levels before the patient went to bed was too high. So, and it can be due to either there's high basal or there's too much bolus. Could be due to anyone. Yeah. But glucose, they took more insulin than they should. Or patient took insulin but they didn't eat as much to justify right that insulin dose. Yeah. So either with there's an hypoglycemic episode during the night that will trigger rebound hyperglycemia. Yeah. Down's effect is just the normal phenomenon because normally during the early mornings there's high catecholamine. That's one of the things that wakes up in the morning. There's increased catecholamine levels in the morning during the early morning hours of the morning. During the yeah, so we call that like Down's effect because they don't need those ones. They are not preceded by hypoglycemic episode. They actually have normal glucose level throughout the day as well as if you check their glucose level during the night, it's going to be normal. They don't have any hypoglycemic episode. It's just and normally during the early mornings of every day, the catecholamine levels are normally elevated. Sympathetic tone is high. Normally, it's a normal physiologic response. That's one of the reasons that keeps us aware, that wakes us up from sleep. So in diabetic patients, if they take insufficient insulin now, so if the insulin patient took, nocturnal insulin the patient took was insufficient, which means glucose is already high. Now you compound that by the normal Dunn's effect that takes place in the morning, then they can actually develop what hyperglycemic or a spike in the morning. So they wake up, they check their glucose is high, but since the insulin level there is since the insulin dose is insufficient already, so you can see two things. Smudges too much insulin, so there's an hypoglycemic episode, then rebound hyperglycemia. In Dunn's effect, they're already taking insufficient insulin. So which means even if I check their glucose level during the day, you're gonna see insufficiently controlled glucose. Glucose will be high. Either postprandial fasting is gonna be high, telling me that this insulin level is already or insulin dose is already insufficient. And then in the morning there will be there will be a higher spike because the insufficient insulin now is not compounded by what? By the Dunn's effect. Yeah, in the morning. Or sympathetic activation in the morning. Yeah. So we call that Dunn's effect. Yeah. So you treat Dunn's effect with what? Increase nocturnal insulin. Readjust the insulin dose, increase it. To treat smoothie, you have to decrease, right? Nocturnal insulin.